Hello everyone, good evening. This is Meera here and we have Sumi with us. Today we'll be discussing an important structured discussion station from the gynecology module. Structured discussions are very important because that is where you are going to score more. That is usually the problem because people don't give much importance to structured discussion stations on your organized approach. Make sure you are structured enough in your thought process, in your answers, so that when you discuss with the assessor, your answers come out in a fashion that you are able to justify your answers and you are able to answer to the question which was posed to you. Okay, so with that in mind, here you go. This is your station. Are you able to see the slide? Your timer starts. Hello, Dr. Khatija. Are you able to hear me? Yeah. Yeah, you're audible. Okay. So here is your first question, dear. What is precocious puberty and what would be the differential diagnosis and causes for her condition?
Okay. This is a 7-year-old that presented with features of early pubertal changes with her parents being worried. So this is the case of precocious puberty. So precocious puberty is when there is sign when there is menstruation before the age of 8, or when there are features of pubertal changes before the age of 8 years old. So the differential diagnosis in this patient could be central precocious puberty, in which case it is from the central nervous system, or it could be central. It could be due to a tumor, like ovarian tumor, especially if estrogen secreting tumor. It could also be from tumor from the adrenal gland. It could be idiopathic as well.
So that's it. Do you have any differential diagnosis in your mind? You mentioned the causes.
Okay. It could be, sorry. Those are all I can think of. The differential diagnosis, it could be idiopathic,
Okay.
it could be primary, that's it could be primary, um, it could be due to tumor from the ovary, it could be
Okay.
due to
Okay.
a
Yes, dear. You mentioned all that. All right. We will move to the second question. Okay. So, how will you gather more information about her condition and justify your approach with relevant history and examination?
okay. So the relevant information I would like to get from this is going to be the onset, since when it has started. I also like to know the duration. I like to know what pubertal changes we've noticed in her, like the menstrual, if it's the menstrual period, breast development, presence of presence of pubic hair. Then I also like to know if she has any other comorbidity like persistent headache, like abdominal pain, abdominal distension. Um, I also like to know if there is any family history of such. Then um, I also like to know if there was any history of maternal. I also like to know. I would like to examine her. In the general examination, I'll be looking at her height to see if I'll be looking at the height. Then I would like to do an abdominal examination for her, checking for any palpable masses. Then I will do a vaginal examination with in the presence of a chaperone. I would like to make the patient, I will create a good rapport with the patient and make the patient feel comfortable about the examination. I will not want to do a digital examination for her because so as not to rupture the hymen. I also like to check for any skin changes, um, to see if there are any striae, if there are any abnormal things that
Okay. So, that's it. What investigations would you perform to confirm the diagnosis and differentiate central from peripheral precocious puberty?
okay, I would like to do the gonadotrophin, the level of the gonadotrophin like FSH,
Mhm.
and then I also like to do the estradiol level. So in the central precocious puberty, I'm expecting the FSH to be low. Um, while in the peripheral, they could be normal with elevated estradiol. Um, I would like to do a transabdominal scan for this patient to see if there is any pelvic masses that can be identified. Then I think the study is I would like to do, and in case the scan is not is not convincing, I might go ahead to do an MRI for this patient.
Okay. So, the child has been diagnosed with idiopathic central precocious puberty. How do you formulate and justify your management plan?
So the management of this patient will involve adequate counseling of the parents about her vulnerability, about the need to monitor her closely so as to avoid any sexual exploitation. Then I would like to administer growth hormone for her so that she can achieve optimal growth levels. Then I'll also place this patient on gonadotropin releasing hormone agonist. Um,
Mhm. Okay.
then um, Then
Okay,
I think, sorry, I
that's
forgot.
that's all right, dear. Anything more you'd like to add? Any other question you would like to revisit?
Well,
All right. So shall we end this timer?
yes,
So you still have
yes.
3 minutes left.
I don't know what to say.
No, you were
I'm
very
just
good, dear.
so
So far, from whatever information that you gave, it was very relevant, and I like your approach, the way in which you structured the answer, and you also justified your answer, why you are doing a particular thing. You rightly justified it, and the you are organizing your thought process. I like it. A little bit of refining, definitely you would need, but it's good to start with. Okay. So overall, your
thank
time
you.
management was good. Okay. And there are certain things like when you're answering, avoid certain repetition, like I would like to do this, I would like to do that. So that you can avoid. You can just go on to this is done. Instead of I would like to do this, you just say whatever is done and why you are doing it. So that would be avoiding this repetition. All right. So sometimes, uh, candidate by candidate, if the assessor is listening to several candidates, certain kind of this kind of repetition zones them out. Okay, they might not be listening to you. So make sure you use certain key phrases and grab the attention of the assessor so that the assessor doesn't miss out on the details which you are mentioning. Okay, make sure you remember that. Apart from that, the way in which you structured your answers, your thought process, I really liked it. Okay. What is your reflection, dear?
Actually,
Tell me your reflection, dear.
I think I did terribly bad. It's been a while I actually visited that topic. So I feel maybe I'll just dust it, I'll go through it again and see and attempt it on my own subsequently. But I think my
Okay.
performance was not good.
No, dear, it was good. It was not very bad. It was good to start with. Definitely, we would need to make it better. There is no doubt there. But it was really a good structured approach, and you were able to answer most of the points. This is something which is known to all of us, right? You would have read it in your part two, and because this is a recall, definitely this is something which all of you would have seen, right? So, how do you structure the answers is what we will see today. Okay. So the first question right now we will discuss the key. All right. So here,
Okay. Okay.
yeah, yeah, we will discuss the key now. Anybody else has anything more to add? Any more points anybody would like to add? If not, we will go with the key discussion. All right. So this is the first question. You can see the question is asking you what is a precocious puberty and what are all the differential diagnosis and causes. Okay. So this is something different. Differential diagnosis is what are all the different presentations, right? What are all similar presentation due to different reasons, and what is the cause for this presentation is the question. So you rightly mentioned about the development of, I think you mentioned menarche. So not just menarche, the development of secondary sexual characters before the age of 8 years in girls is called precocious puberty. So this is a complete information, the complete definition. Okay. So this may present as thelarche, pubarche, or menarche. And you will also see a rapid growth spurt in the patient. So the differential diagnosis for a precocious puberty is it could be a benign variant. So this is the differential diagnosis. It could be a premature thelarche, adrenarche, or isolated premature menarche. So these are all the differential diagnosis. The causes why she presents with precocious puberty. The causes is what you described. Okay. So as per what is the background, could be a central precocious puberty or a peripheral precocious puberty, or it could be any of the benign variants, right? The central causes, like you mentioned, the CNS lesions, Okay. Hydrocephalus, head trauma. Okay. So these are all the central precocious puberty. Most commonly, what we see is the idiopathic precocious puberty. So this is how you have to mention to the examiner. Most often, this is due to central precocious puberty, is due to the idiopathic cause. Otherwise, the other reasons could be, these are all the other reasons. So this is how you need to mention. Instead of just enumerating it one by one, you just organize your thoughts and discuss and talk, converse with the examiner. All right. Like you said, the peripheral precocious puberty could be ovarian cause, adrenal cause. You mentioned all these things. Make sure you don't forget this McCune-Albright syndrome and the exogenous sex hormones. The baby, the girl can come across like oral contraceptive pills, skin creams, cosmetics, right? Anabolic steroids. So the girl can come across these things. That could be the reason, right? So these are all going to be peripheral precocious puberty. Benign variants, again, that is one of the reason, and that is one of the differential. And one more thing you need to mention here is how it presents, right? How it presents, whether it presents in an isosexual manner or heterosexual manner. So this is one of the most important points which is usually forgotten. Usually the central precocious puberty presents in an isosexual manner. That is, the pubertal changes are appropriate for the child's sex. The child is a girl, the development is going to be along the lines of female, right? So that is how the central precocious puberty develops. Peripheral precocious puberty can be both. It could be heterosexual. So this is how you have to frame your answer. All right. This is one point which is usually missed. All right. Now, the second question was, how will you gather more information and justify your approach with relevant history and examination? So this is very specific. They're asking you only the history and examination. Whenever you have a history and whenever you have a young child, make sure you mention certain things like sensitive approach. Mother will be anxious. The parents might be anxious. Address that. Introduce self. These are some things you should never miss for any structured discussion station. The communication with the patient part also should be discussed. We will be offering them written information. We will be asking for doubts and allaying their anxiety, asking for any questions they might have. This also is part of the management process. Make sure you mention this in your management for any structured discussion station. So once this is done, you go to the crux of it, what you're actually going to do. You look at the presenting complaint. Like you mentioned all these things. What was the symptom, what symptom was noticed first, and most important is the speed of progression, whether it was rapid or it was slow in onset. So that is going to tell you about the reason why this precocious puberty is setting in, right? So this helps determine whether puberty is progressive or non-progressive. Now, what kind of symptoms she had, which helps us in identifying the pattern of puberty. Now, the growth history, don't forget this one, because there is going to be a growth spurt. If this is due to the central cause or even the peripheral cause giving rise to hormones, she is going to have a growth spurt. So this was identified or not. Okay. And whether she had any virilizing symptoms, whether it is isosexual or heterosexual, this you would need to mention it here. Okay. And you mention neurological symptoms, what like increased intracranial tension in terms of headache, vomiting, visual disturbances, seizures, anything at all to look at the CNS etiology. Okay. And the drug and exposure history, because these are all the hormones which could be exogenous, which could bring about these kind of changes in the young girl. So I would be asking about the hormonal creams, or she came across any of the cosmetics or any pills that she could have her hands on. So this is something you would be asking. Okay. And family history is very important, whether this child is an adopted child. Okay. And what about her mother or her siblings? What kind of course they had around their puberty? So this you would need to be establishing. All right. And psychosexual history and safeguarding points. These are most important safety points. You should never miss it. Okay, because as such, when a girl has this kind of symptoms and she presents with this, there's going to be emotional distress for her and for the parent, and among her peers, her behavior might change. Okay, or she might be under the possibility of sexual abuse, and there is also a possibility that this is a presentation of sexual abuse, like isolated menarche, right? So this is something you should be mentioning. And why you think in terms of this, you would need to justify to the examiner. Okay. Am I clear so far? Yes? Could
Yes,
anyone
ma'am.
Okay.
Yes, ma'am.
Okay. Thank you, dear. So coming to examination in the presence of chaperone with her consent. Okay, you have to explain to the child what you are going to look for, and you mentioned that you will build a rapport with the child, and then you will examine her in the presence of chaperone. This you mentioned. I think you mentioned this examination of chaperone when you did the vaginal examination. It's better to mention it at the start. Okay, at the start of examination itself, you can mention that I'll be examining with the chaperone, the presence of her mother, if the child is not comfortable, and I'll create rapport with her. So this way you can open this. Okay. Now the examination, make sure you mention this head to toe examination, what you are looking for: height, weight, BMI, growth chart plotting, how her growth was previously, whether there is any K-Foley spots, right? So those things you have to mention from head to toe. Any structured discussion, any examination, make sure you mention the vital signs and head to toe examination, any relevant points pertaining to that particular case. Never miss that. Okay. Now, the key points in pubertal assessment: the Tanner staging, what kind of breast development, pubic hair assessment, all will be done in a structured manner. And in the general examination, I'll be looking for any acne, hirsutism, K-Foley spots, and any pointers for the thyroid disease. Okay, and this you mentioned, this is what I liked. I'll be looking for abdominal masses. I'll do an abdominal examination and I'll look for any masses. So this is how you would need to be talking to the assessor. Just abdominal examination is not going to be sufficient. You are going to justify why you are seeing that particular. So this is what I would want. So why you are doing that, and your justification, make sure you mention that. And neurological examination for cranial nerves, visual fields. So this will be the examination findings. Now, the next question is about the investigations. Would you perform to confirm the diagnosis and differentiate central from peripheral precocious puberty? Now, this is a very specific questions. They are asking you about the investigation to confirm the diagnosis and that to differentiate the central from peripheral precocious puberty. So the investigations here is aiming to do the same, right? So the presentation could be different in central and peripheral. So you can start from there. The presentation is going to be different, and apart from that, the investigation is going to help you confirm. So the baseline hormonal profile, you are going to do LH, FSH, and estradiol. But the talk says estradiol is not going to be much useful. It can be, not very much clear when it comes to the levels and depending on the estradiol level. So this may or may not be the most important test. But the gold standard test is the GnRH stimulation test. So this is the keyword which I was mentioning, which you would need to utter to the examiner. The gold standard test to differentiate central from peripheral or even the isolated thelarchy is the GnRH stimulation test. And what response are you expecting when you see a central precocious puberty? This you would need to highlight. The if LH-FSH level more than 1 is suggestive of the central precocious puberty, and at that particular age, if I see this response, this is diagnostic of central precocious puberty. So this is how you would need to be telling the answer. The additional tests, of course, you will rule out the other conditions like, the TFT, prolactin, 17-OHP, VAS based on her presentation. Okay, she might be having any androgenic features or any headache or associated hyperprolactinemia symptoms or thyroid focus related symptoms like cold intolerance or cold, her BMI may be on the higher side, right? So these are all the things you will rule out on suspicion. And the most important next point to mention is the bone age. Why you are seeing the bone age? Because you would want to rule out, you would want to see whether the bone age is advanced for her age. Okay, this is another investigation which you should not miss. One is GnRH stimulation test, another is the bone age. And then, of course, like you mentioned, you'll do a pelvic ultrasound and you will be looking at the cyst tumors, or in the adrenals, you would be looking for any tumors. All right. Now, You will not be going in for CT or MRI immediately for all the patients. Depending upon her symptoms, depending upon her presentation, you would be doing this. This is how you would need to tell. You should not be telling one by one, like, when we were undergraduates, we will mention all the investigations. So this is not how you would need to, you should be talking. You would need to tell in terms of how you cater a particular investigation for the presentation. So if I see any mass, if in doubt, I would be arranging for further investigation, maybe the CT or MRI, depending upon whether it's abdomen or a CT brain or MRI brain, depending upon the presentation. So this is how you would need to mention. Okay. Now, so this is how you will differentiate. You can see based on the presentation, you can differentiate central from peripheral in terms of how the sequence is. So this is the way in which the central precocious puberty presents in a normal sequence. Here it could be discordant, like one of the features like thelarchy, pubarchy, or menarche. It could be up and down. It need not be in the same way in which you will see a growth spurt, and then you will see a thelarchy, and then the pubarchy, and then the metamenarche. You might not be seeing it in the peripheral type. And usually the common causes for central are like previously, like how we discussed, the idiopathic CNS lesions and brain tumors, and hormonal pattern, like just how we discussed, LH is going to be predominant, right? And here in the peripheral precocious puberty, based upon the presentation, you would be arranging for specific investigation workup, which you'll be able to diagnose the reason. Okay. But this question was mainly about the investigation and how you will differentiate it. So the previous answer was sufficient. Now here the child is diagnosed with idiopathic central precocious puberty. How would you formulate the management is the question. Now this is the question which needs more focus, because you see a lot of red points, right? These are all the points you should never miss. These are the safety points. So the answer to this question should be this: based on the cause. I would be managing the patient based on what exactly is her cause. This is the point which you should never miss. Because of course, all of you will mention the medical management, all of you will mention the GnRH analogs, okay? And well-prepared candidates might also mention the doses for these drugs, okay? The side effect for these drugs, all right? But you should never miss this point. The based on the cause, I will manage. Sometimes if the patient has a slow progressive form, watchful observation is also acceptable. This is another point which can be missed. All right. So these are the points which showcases that you are better, or you have had a better understanding when compared to your peers, right? So mention the goals of treatment, that it is to halt the pubertal progression, preserve the adult height potential, delay menarche, and reduce the psychosocial distress. So these are the goals of the treatment, and the various treatment options available. The first line is going to be the GnRH analog, and it is available in various formulations, which, the dose and frequency based on the preference you will go about. Now, for any management of this kind of presentation, make sure you mention the MDT. Your management step should start from the MDT, who are all the disciplines that you will be involving. Don't forget to mention the pediatric endocrinology, pediatrics, family support, psychological support. She will require counselors. She will require her GP for the follow-up, the specialist nurse, right? To discuss about how she should come up for the injection, right? So all these things should be part of the initial part of your answer. Now the GnRH is the mainstay of treatment, and when she is on GnRH, you will be monitoring. And how long she should be on these medications should be based on a joint decision with the family, child, and the parents, along with the endocrinologist. Till that point, you'd be continuing. Usually around 12 years or so, it will be stopped. But even before, if the family wants and if the endocrinologist feels, with the following the discussion, you can stop the medication. And how are you going to monitor it? You're going to monitor it by the growth velocity, the clinical points, and the hormonal profile. The hormonal profile will show a suppressed LH response. Okay, clinically, you'll be able to see the growth velocity coming up, the Tanner staging stabilizing, and the bone age. You should be doing on and off X-rays. Okay, so this is how you will monitor. At the same time, counsel the parents. This is one of the most important points. Sometimes parents might think that once the treatment is given, she will never be able to attain menarche later on when she is of age, right? So the mother or the parent needs to be aware that the treatment is effective treatment and it is reversible. Once you stop the medication, she will go on with her usual routine development as expected. Okay, this you would need to mention. And for any drug, make sure you do not miss the side effects. What are all the side effects? Headache, hot flushes, sometimes PCOS type of presentation can be there in later years. This you would need to tell the parents. Okay, apart from that, support, safeguard, because this is a child with the precocious development. So safeguarding and regular MDT review, documentation and follow-up should be mentioned. Okay, this is how you would need to structure your answers. All right. Now the domains under this task are how you look at the presentation. What is the tempo of progression, like the speed of progression? Okay. What are all the symptoms which she presented with? Any other neurological symptoms? Any exposure of drugs, right? Family? Is she an adopted child? Okay. How is her psychosocial assessment? Okay. So these are all the welcome, dear. These are all the points. Now, coming to the communication with colleagues, this is how you should be starting the management. As I repeatedly say, start the management with the involvement of MDT, and how you logically answer the question with justification is going to fetch you the marks. Okay, and you can ask the assessor to repeat the question, and you can revisit any question if you had some more points to add at the end of the station, if you happen to have some time. Now, the applied knowledge, all of you will be scoring well here, but you need to showcase it in terms of structuring your answers. Like, I'll be treating based on the cause, and this is the treatment which is the gold standard. This is the first line investigation, right? Something like that should be mentioned. Now, patient safety, make sure you rule out any CNS lesions, and rapidity of the symptoms might indicate any tumor. Okay, and mention the safeguarding concern, right? So these are all the safety points. Communication with patients is usually overlooked in any structured discussion stations. Make sure you mention those points, like creating rapport, like how Dr. Khatija mentioned, creating a rapport, sensitive approach, asking, giving them an opportunity to ask doubts, giving them written information, putting them in touch with counselors, support groups, and follow-up plans. So this is how you would be showcasing this particular domain in any structured discussion tasks. So the high yield phrases, like I have put up, you have to mention these points. It's idiopathic most often. It is important to distinguish central from peripheral based on presentation and the investigations. And this GNRH stimulation test is the gold standard, and management is multidisciplinary. And make sure you do not forget that safeguarding concern. Okay. So this is the structured discussion station which we wanted to discuss with you guys. Thank you everyone for patient listening. Any points you would want to add or any doubts you have?
Thank you, ma'am. Thank you so much.
Most welcome, dear.
Ma'am,
Sumi, any points you have? Yes, dear.
Ma'am, can you show us the first slide?
Who is
The
this, dear?
first one. First
Hello,
question.
hello,
I'm
Dr.
Ragini.
Ragini. Hello, Dr. Ragini.
I joined very late. I'm sorry.
Oh,
But
missed you,
I
dear.
tried
No
to
worries.
join. Somehow I
No
tried to
worries, dear.
join.
No worries, dear. You are welcome. So this is the first slide, dear.
Okay, ma'am. Thank you.
Welcome, dear. Any doubts, anybody? Okay, Sumi, please, your inputs, please.
There is nothing I would like to add. It is complete along with the theory, clinical part. Everything is completely covered. Nothing to add to this.
So I hope our participants found it useful, and hopefully you'll be able to remember when this task comes to you for your exam.
Yes, ma'am. It was very nicely done.
Thank you, dear.
Very nicely done. Thank you so much.
Welcome, dear. Any other doubts? If not, we shall end the session. I think it will itself by itself stop. Okay.